Touchette, thank you for joining us today. We're very excited to have you. Hopefully, you're not super tired from your esport traveling. Uh, Always a pleasure hearing you. So, for those of you who may not be familiar, Dr. Touchette is a professor in the Department of Pharmacy Systems, Outcomes, and Policy at the University of Illinois, Chicago. He received his BS in pharmacy from the University of Manitoba in Canada and his Pharm.D and Master of Economics degrees from Wayne State in Detroit. Sorry, I got a pop-up that I was muted, but I'm using the other mic. He also completed a fellowship in pharmacoeconomics and outcomes research at Wayne State. His primary research interests are in pharmacoeconomics and outcomes research. In particular, he's interested in assessing the effectiveness and cost-effectiveness of clinical pharmacists and other health practitioner services, developing and assessing methods for improving adherence to medications, and evaluating the cost-effectiveness of pharmaceutical agents. So without further ado, thank you so much, Dr. Touchette, and I'll turn it over to you.
All right. Thank you, Dr. Salgado. Everyone, you can hear me all right? All right. So I'll move forward. Thank you for that introduction. Today, we're going to be talking about medication therapy management. I'm going to introduce some of the concepts of medication therapy management. Then going to discuss clinical outcomes evaluation of the University of Illinois Health's MTM program or clinic. Then we're going to talk about just very briefly, some of the methods, give you a little bit of a primer so you can, for those of you who are less familiar with economic analysis, you can see some of the methods that we're using and how they work. Then I'm going to talk about two different evaluations that we did, assessing our medication therapy management program. First one, very briefly looking at an assessment of hypertension management. And then the second one, a more detailed case looking at diabetes management. And then the discussion and conclusion. As most of you know, it takes a village to be able to do these types of studies. And so for the three studies, I wanted to acknowledge my co-authors on each of these different papers, and they're listed here. So what is medication therapy management? There was a consensus definition that was generated by a number of pharmaceutical organizations and published in 2005. So it's described as a distinct service or group of services that optimize therapeutic outcomes for individual patients and are independent of, but can occur in conjunction with the provision of a drug product. The goals of medication therapy management are fourfold. They're to enhance patient outcomes. So looking at the clinical benefits of MTM, they can also improve adherence to medication regimens, prevent medication errors, and reduce the risk of adverse drug events or drug reactions events. At UI Health, our MTM clinic is a long-standing clinic. It was in existence even prior to the legislation that introduced medication therapy management. And our clinicians here offer longitudinal pharmacist-led services to patients in need of global medication or disease state management. The services are primarily given to underserved African American and Hispanic population that UI Health serves. Patients are seen for a 1-hour initial visit and a 30-minute monthly follow-up visit. And you'll see why the services are so intensive in a second. And the program is coordinated by three full FTE pharmacists, one technician, one externer, and a number of learners, pharmacy students, residents, others. So the role of our MTM pharmacists is shown on this slide. This program actually started as a refill program to try and synchronize refills. This is still done. So we synchronize the fills for patients, and we also pre-fill pill boxes in those patients who need that type of a service. So those are some of the medication adherence tools that are delivered. For disease management and medication management, there's a number of different focuses. There's hypertension, diabetes, renal dosing, tobacco dependence, and asthma are kind of the key focuses of the disease management aspects of the program. Down in the bottom left, the service also facilitates transitions of care for patients. So the pharmacists will do medication reconciliation at each visit and also provides medications at discharge for established patients who are admitted to UI hospital. And then the final quadrant, the bottom right hand, the MTM program or MTM clinic also provides other services to improve medication adherence, health literacy, and provide education to patients. So here's the slide that I was talking about. This is the MTM clinic at UI Health is a referral clinic. And you can see here the mean age of patients, the proportion or the number and proportion of patients who are dual eligible. So we have a very relatively older population, the vast majority of whom are dual eligible. And here the mean number of diagnoses per patient is just under 10. The number of visits per month is just over 1. The number of medications per patient is around 15, and the number of daily doses per patient is about 20 doses. So this is a population who has multiple comorbidities, multiple issues that need to be addressed. And often, although it's not shown here, often patients have difficulty with adhering to their medication regimen. And so these patients are seen frequently by our pharmacists, and we do a lot to try and assist patients with taking their medications. So here is the first question that I have for you for the CE purposes. Which of the following is not a responsibility of pharmacists in the UI Health's medication therapy management clinic? A, to improve patient adherence to their medication regimen. B, facilitate patient transitions from hospital to the community. C, adjust medication dosing for renal impairment. Or D, all of the above are responsibilities of the UI Health MTMC pharmacists. All right, in the chat, I'm seeing a number of answers. Good. The majority of you have picked D, all of the above responsibilities of UI Health MTMC pharmacists, and that is the correct answer. All right, so we're going to move on to the next the next piece of this presentation, and that's one of the goals of my research program is to evaluate the impact of clinical pharmacy services on patient care. And so in discussion with Jessica Tilton, who's the lead author on this first paper, and is the director of the MTMC at UI Health, we decided to undertake a study to look at the impact of the medication therapy management clinic on glycosylated hemoglobin, blood pressure, and resource utilization. This study was a retrospective matched cohort study. It was a two-group design, so we had patients who were part of the MTM clinic, and we matched them one-to-one with patients in UI Health in a number of different clinics that are the clinics that typically refer patients to the MTM clinic. And we included all those patients who had diabetes and/or hypertension. They had, for the intervention, they had to be MTMC patients. For the control, they had to come from UI Health's internal medicine clinics. And again, we matched one-to-one. The factors that we matched on were age, gender, and presence of diabetes, hypertension, or both. The outcomes of this study, we evaluated a change in mean A1C for patients with diabetes. and change in mean systolic blood pressure and diastolic blood pressure for those with hypertension. For those with both, we evaluated both outcomes. The secondary outcomes included change in the mean number of diabetes and hypertension-related emergency visits and hospitalizations. The statistical analysis, because this is a referral clinic, we were concerned that even if we did adjust for common confounders, that we still would have residual confounding in the analysis. And we actually did a difference in difference approach to try and remove or mitigate the impact of those potential confounders on our analysis. So for those of you who are not familiar with the difference in difference approach, we looked at the difference in the outcome of interest at the beginning of the period, as well as at the end of the period, and we measured the change in that outcome over time and compared the change in those outcomes, just as a really high level explanation of what a difference in difference design is. Here are the baseline characteristics. Because we did match, you'll see that many of these baseline characteristics are pretty much identical. Where there is not matching or where there was incomplete matching, we do have some slight differences, but none of them were really problematic. When you look at the comorbidities, we did have a little bit more asthma. This is something that we did not control on. So we did see a higher proportion of patients with asthma, higher proportion of patients with, where did it go? A little bit higher with mental health issues, primarily depression in the MTM group. So you can see it was not a perfect matching, but we did include, with the difference in difference approach, hopefully we'd be able to address some of these differences that we did see at baseline in comorbidities. Here are the results of the evaluation of A1C. And you can see that at baseline, well, let me describe the axes first. So we have mean A1C on the horizontal axis. We have months from index date on the, I'm sorry, I said that wrong. Mean A1C on the vertical axis, months from index date on the horizontal axis. And you can see that at baseline or in the pre-period, that MTM patients had a higher A1C than did those in internal medicine. And then at the 12-month post, we did see a pretty dramatic reduction in A1C in the MTM and not in the control. Systolic blood pressure, although a little bit less pronounced, we saw similar results with blood pressure in the pre-period to the post-period. In diastolic blood pressure, again, we see the same thing. So in the end, these were, this is a summary of the results. At 12 months follow-up, we saw an 8.21 millimeter mercury reduction in systolic blood pressure and a 0.63% reduction in hemoglobin A1C. I just wanted to present that study quickly because those are the results that we use to then look at the long-term outcomes associated with our medication therapy management program. So I wanted to give you that background. Now I'm going to move to some of the methods that we commonly use in economic assessment of programs or of medications too. So there are a number of different ways to formally combine evidence. If we're looking at a single outcome of interest and we have multiple studies available to us, we can do things like classical meta-analysis or meta-regression if we have access to more detailed data, the primary data from, say, several clinical trials. When we have multiple studies that we're trying to compare, and we have a common comparator that we can use, or multiple drugs that we're trying to compare, and we have a common comparator, or in this case, if we had multiple studies evaluating the same programs, and they're being compared to a common comparator, we could also do something called network meta-analysis. And we do see this type of approach often to evaluate a single, say, clinical outcome where there is a lot of evidence, and we want to combine that evidence. However, when we're doing economic analysis, we have a different problem in that we're trying to bring in more than just a single clinical evaluation. And so we're trying to bring in costs, quality of life, clinical outcomes into a single analysis. And so these meta-analytic methods, although they might be used to generate some of the evidence that we need, are often not able to do what we're looking to do with combining multiple types of evidence. And so we often we move to this other methodology, decision modeling, which is a quantitative method that can be used when direct evidence is not available. So here we have a lot of indirect evidence. We might have information about costs of care. We might have information about long-term outcomes of care, but not directly pertaining to the evaluation that the program that we're trying to evaluate. So we can use decision modeling, and there's a lot of different types of decision modeling. We can use decision modeling to combine these different outcomes that we're trying to bring in. Like I said, there's cost information, there's quality of life information, there's clinical outcomes of interest, and they may all come from different studies. So with decision modeling, we can incorporate this indirect evidence and assumptions in the model as variables. We can use mathematical calculations to simulate event probabilities and calculate outcomes. And then we have a whole set of tools that allow us to determine the robustness of our results. So examples of simple, examples of simple models include epidemiologic models, and even Bayes' theorem is actually a model. It's a series of mathematical calculations to help us determine the utility of a diagnostic test. More complex models are things like simple decision trees and Markov models, which can be used to model more complex decisions. There are certain advantages to decision models. So by combining evidence from multiple sources, decision models allow the researcher to extend empirical results to a variety of populations through modeling different subgroup analyses or different studies, or looking at real-world data to enhance some of the inputs in the model. We can also look at longer time frames. So, our study was looking at 6 and 12-month outcomes, but how do those outcomes extend to longer, more terminal clinical benefits? We can extend the time frame in which we're doing the analysis. And it can also look at different settings, so we can evaluate different scenarios, different situations. There are many different modeling methods that are available depending on the type of problem that's being addressed and the availability of evidence to inform that problem. So there are simple decision trees, Markov models, discrete event simulation, multi-state partition survival models, microsimulation models. Each of these model things in a slightly different way to overcome some of the limitations and some of the issues that we might encounter with the types of data that we have. So The two most common are probably simple decision trees and Markov models. Simple decision trees are particularly good for evaluating acute conditions where there is no repetition in the outcomes over time. Markov models do a much better job of modeling um, chronic conditions where there is repetition, where somebody could have more than one myocardial infarction, or somebody could have more than one, where a problem recurs. Markov models handle that type of situation a lot better. And these others all have certain benefits. I'm not going to get into a full lecture on each of these different modeling approaches, but there are different benefits to these others. So because we're going to be talking about chronic conditions, we modeled using Markov models. I'm going to quickly describe for those of you who are less familiar with Markov models how they work. So we start out by defining particular health states, usually health states. They can be other states. They don't have to necessarily be specific to health, but they're typically health states when we're modeling these types of conditions. And patients can move from one state to another in a predefined period of time. So, and that period of time is called the cycle length. So in our models, we had a 1-year cycle length. So within a 1-year period of time, patients could move from one state to another like this. So patients move from state A to state B according to a particular probability of that occurring at a point in time. Likewise, patients can move from state B to state A at a particular with a particular probability of that occurring in that defined 1-year period. Also, patients can move within a state. In this case, I showed patients moving from the absorbing state to the absorbing state, also with a specific probability. So each of these health states are defined. The absorbing state is the final state that people move into. For most Markov models, that absorbing state is death. So we model patients over their lifetimes, 1 year at a time, sort of tracking how they move to these different health states. And then we apply a cost for being in each of the different health states, as well as utility, which is a specific type of quality of life measure. So they gain costs over time, and each patient will gain, or each group of patients will also gain utility over time until everybody eventually is in this absorbing state, which, as I said, is typically death. So that was a very quick primer on how a Markov model works. And how some of the benefits of decision analysis. So here's a question for you. The main advantage of using decision analysis to determine the cost effectiveness of treatments or programs is that decision modeling methods allow the researcher to A, statistically compare the results, B, combine indirect evidence, C, reduce bias in the inputs, or D, leave work early. Right, we're starting to see some answers coming in. I'm seeing most people are answering B, which in this case is the correct answer. That is the main advantage of using decision analysis. If we were to develop a prospective randomized controlled trial evaluating medication therapy management and its impact on mortality, we could do something. We could do a study like that. It would probably take many, many years to conduct a study like that. If we think about, evidence for statins, the main evidence for statins reducing mortality was the 4S trial. And I like using this one as an example because the 4S trial, the Scandinavian Simvastatin Survival Study, had 4,444 patients evaluated over 4 years. It's easy to remember this one. And that's, it took all 4 years of the study to detect the impact of statins on mortality. If we were to do a study like that in 150 MTM patients, we would have to follow the patients all the way through until probably every last patient had passed away in order to determine the impact of medication therapy management on that. So that would be a very long study, very complicated and very high cost. So D, leave work early, is potentially one of the correct responses here. But that's not the main advantage of using decision analysis. Really combining indirect evidence is the main advantage. Be able to do this for less cost in a shorter amount of time. There are certain trade-offs with using decision analytic methods compared with, say, a prospective randomized trial. It does allow us to leave work early, but it doesn't allow us to definitively answer a question the same way a prospective randomized controlled trial would. All right, so now I'm going to talk about the two studies that we conducted, the two publications that we have evaluating longer-term outcomes related to the benefits that we saw, the reduction in hemoglobin A1C and the improvement in blood pressure. I'm going to start out with the hypertension evaluation that we did. We did this one first because it was easier to model than the diabetes one was. So here are the authors of that publication, which was published in Value in Health in 2021. So this study is a Markov simulation model. The population were all of the patients in our study, in our previous clinical study, who had hypertension and no history of prior cardiovascular disease. So we focused on primary prevention for this one. The intervention was the medication therapy management. The control were patients without MTM. The outcomes evaluated were stroke, MI, and other cardiovascular conditions that were all lumped together. So TIA, peripheral artery disease, angina were all grouped together. The terminal outcomes of this study were the costs, the life expectancy, quality adjusted life years, and ratios of those. So cost per life year gained, cost per quality gained. And we evaluated patients over a 10-year period. The perspective was the health system perspective. The thresholds that we used to consider whether or not our intervention was cost effective were 100,000 per quality gained and 150,000 per quality gained. We did threshold analysis and sensitivity analyses to look at the robustness of the data. Just to quickly go back for those of you who are less familiar with the quality adjusted life years gained, I had mentioned that utilities are a specialized method of assessing quality of life, and quality adjusted life years gained is the combination of life expectancy and quality of life over a patient's lifetime. So it's a measure that incorporates both quality of life and life expectancy. Here is the model structure that we used. So everyone started out in this hypertension state. Everyone included in this were those who were diagnosed with hypertension. The outcomes were myocardial infarction, stroke, or other CVD event, as I described earlier. And after patients had one of these events, they would move into this chronic CVD where they would require additional medical management over time. But from this chronic CVD state, they also could have a second MI, second stroke, or a combination of either of those, or develop another CVD event. We also had what are called tunnel states between these different events and chronic CVD. So for patients, say, who had a myocardial infarction, their risk of having a subsequent MI is higher for the first few years until it finally falls to kind of a more steady state type of level, which is when they would end up in the chronic CVD state. Likewise, with stroke, we incorporated higher risks of other cardiovascular events occurring post-stroke. At any point in time, from any of these, patients could die of natural causes or could die of CVD-related causes. and would end up in this death state. So that's the model that we used. What we did was we built the model using the Framingham risk equation, which gave us the probability of patients having stroke or other CVD event. And then we built in those utility inputs that I described, those quality of life inputs. So patients who had a stroke, MI, or other CVD event had a worse quality of life than those who had hypertension only. And then we also built in the cost inputs. Those both the utilities and costs were derived from a systematic review of the literature where we identified the best available evidence to include in the model. I'm not going to go over this too much, but the Framingham risk equations that we incorporated into the model are mathematical equations that predict the risk of bad outcomes for patients with blood pressure. And basically what we did was we incorporated in our MTM cohort an 8.2 millimeter mercury reduction in systolic blood pressure, ran that into the Framingham risk equation using our model, and came up with a 10-year cardiovascular event risk. And so based on it, and then we calculated the annual risk and put that back into our model, which evaluated things on an annual basis. So here were the numbers that were entered into our model. The probability of stroke from primary prevention was about 1.1% per year in the MTM clinic, 1.2% in those who were not in the MTM clinic, who did not have that benefit of a lower systolic blood pressure. And you can see across the board, there were benefits for a number of different events that were built into the model. Here are the utilities for each of the disease states. So for those who were hypertension only, their quality of life each year was 0.86, or their utility value was 0.86. For stroke, it was 0.65, so significantly lower. For MI, 0.7, a little bit better than stroke, but less than primary prevention. And for other CVD events was 0.7. Once patients stabilized and had a history of any of these things, their utility was about 0.73, so a little bit better than the acute situations, but worse than they were with primary prevention when they had lone hypertension. Here are the costs in the model, same type of thing. So big costs for the acute events, smaller but still big costs for the chronic management of patients over time. So the lowest cost state obviously was primary prevention. Here are the results of this model, and I'm just going to focus on the main outcome because, again, my goal is not to present this particular model other than to give you some of the background for our diabetes model, which I will cover in much more detail. But what we saw in the end was the cost per quality gained for the MTM clinic versus no MTM clinic was $47,000 per quality gained, for almost $48,000 per quality gained, which actually was well below the threshold values that we were expecting of 100,000 or 150,000 per quality gained. When we looked at this in a different way, doing a threshold analysis where we increased the cost, the reimbursement per visit, so our base case value is very close to the 50,000 per quality gained estimate. But when we looked at a threshold of 100,000 per quality gained, we found that pharmacists could theoretically be charging $200 for their initial visit and $102 for each follow-up visit and still maintain 100,000 per quality gained value, which is actually still a pretty low value when we look at therapeutic interventions. For drugs, we often use a value of 150,000 per QALY gained, in which case pharmacists could be paid up to $282 for the initial visit and $141 for each follow-up, and still provide this level of value in healthcare. So here's the next CE question, just to check if you're all staying awake for this. Which of the following best describes the results of the base case analysis evaluating the impact of UI Health's MTMC compared with no MTMC for patients with hypertension? So we saw lower cost and lower effectiveness, higher cost and lower effectiveness, lower cost and higher effectiveness, or higher cost and higher effectiveness. I'm seeing a lot of C's. I'm seeing at least one D. And I did kind of quickly go over these results. The correct answer actually is D, higher cost and higher effectiveness. So if we go back to this slide, which I did skip over, and I apologize for that, we see the MTM costs for the payer would be, this is in the full 120 patients who are part of the MTM clinic. These are the lifetime costs. It would cost the payer $1.4 million. And the direct medical costs for the payer would be a little over $8 million. With the no MTM clinic, we would see obviously no cost for the MTM program. We would see almost $8.6 million in medical costs, which are those costs for myocardial infarction, stroke, and other management in the post period. So the difference was actually for the two, there was, if you add all of this together, it's actually a higher cost for the MTM clinic. We do see a gain in QALYs and in life years and in fewer cardiovascular events. So we see clinical benefits, but the costs of those clinical benefits are not they're not bet more when we add in the cost of the MTM program itself. MTM actually leads to higher costs overall for the payer with higher benefits or higher effectiveness. So D is the correct answer here. And that's the case with most medicines and most interventions that we make. They're higher cost, but we do them because they provide some value. All right, over the next 10 minutes or so, 12 minutes, I'm going to talk about this final study, which was just published in JAFA in February of this year. Again, it's a Markov simulation model. It's a more complex model because we're modeling a more complex condition with diabetes than we did with hypertension. The intervention, again, is the medication therapy management program of UI Health. The control patients are the same patients I described before. They're patients without MTM who are coming from our internal medicine clinics. The outcomes are total costs, life expectancy, quality adjusted life years, and again, ratios of costs to each of these other outcomes. The timing is lifetime. This time we did a lifetime model from a US payer perspective. And we used a single threshold this time of 100,000 per QALY gained to evaluate whether or not this program was cost effective. And we, again, did threshold analyses, sensitivity analyses on all of this. The modeled events in our model, in the base case, we included no complications, ischemic heart disease, stroke, myocardial infarction, heart failure, and renal failure. And then we also built in a couple of scenarios where we included blindness or amputation. We did not do a model that included both blindness and amputation. Here is our base case model. So you can see there are a lot of potential health states that patients can move in and out of, but we start out with no complications for the majority of our patients. And then They could have ischemic heart disease, they could have a stroke and end up in this post-stroke state, have an MI, end up in the post-MI state, and then combinations of these. They could be post-MI and post-stroke. And then for those with heart failure, they could be heart failure alone or heart failure and post-stroke. And then anyone who developed renal failure, the model is sort of replicated for those with renal failure, but instead of no complications or IHD, renal failure is added to each of these different states. And then out of any of these states, patients could die at any time from any cause mortality, as well as cause-specific mortality. So, for those who had an MI, the mortality was higher than the general population, and that was modeled as such. So they had higher risk of mortality. For the intervention effect, we evaluated only those patients with diabetes. So the numbers are a little bit different than what you may have seen in the previous analysis for the hypertension piece of it. But because so many of our patients did have an elevated systolic blood pressure, and the MTM program actually did lower systolic blood pressure to a greater degree than was observed in the control group, we also built blood pressure into our model. So we saw a 0.63% reduction in hemoglobin A1C overall, and an 8.81 reduction in systolic blood pressure. And those were the primary inputs that were added to the model that we built that described the benefits of MTM. Here is the baseline patient characteristics for our population. So for age, about 62 years of age, almost 14 years with diabetes before they were referred to the MTM clinic. You can see the BMI, hemoglobin A1C, systolic blood pressure, and all of the other information for the model. Again, the only thing that we changed in our model was the starting hemoglobin A1C and blood pressure, which were better in those patients in MTM. Everything else was maintained the same. Excuse me. Here are more baseline patient characteristics. So majority of patients were female. Race was predominantly African American, and you can see the percent of patients with other comorbidities here. And this was those comorbidities were at baseline. Here were an example of the event rates that were inputted into the model. These event rates were taken from the UK PDS study, or were calculated from the UK PDS equations. And I'm going to talk about that in a little bit. But what we see is the risk of ischemic heart disease was about 0.83% in the first cycle. For myocardial infarction, it was a little over 1%. For stroke, it was about 0.6-ish%, and so on. So these were the annual risks of developing any of these complications from diabetes. Here are the mortality risks that were obtained from a variety of sources. And these were risk ratios. So if someone had ischemic heart disease, they had about a 1.5 times risk of dying in that particular cycle. For myocardial infarction, the risk of dying was between 6 and 8.5%, and then dropped after the second year post event. You can see these results here, or not these results. These inputs are stratified as well by gender. All right. Oh, before I get to costs, I did want to describe that events in the model, like I said, were drawn from the UK PDS risk prediction equations, the same way that we employed the Framingham study equations for patients with hypertension. We built these probabilities of the events occurring into our model using the UK PDS risk equations, which allow us to evaluate the impact of different comorbidities as well on risk of patients moving through the model and eventually into the death state in our model. Here are the costs that we incorporated into the model. We have about $25,000 for ischemic heart disease for the first year, and then $2,000, a little over $2,000 for each subsequent year. For myocardial infarction, it was about $67,000 for the acute episode and following patients up for that first year, and then about $2,200 for the second year. For stroke, we had a little bit lower cost than myocardial infarction in the first year costs, but the subsequent year costs were considerably more at $18,000 a year. And you can see for heart failure and for renal failure being a very costly condition to manage in the first year and in subsequent years. Here are the utilities for each. For those patients who had diabetes but without other complications, their utility value was just under 0.8, so relatively close to the patient to the population value, which is usually around 0.8 to 0.84. A little bit lower though. And then for each of these complications, we applied a disutility to them. So for ischemic heart disease, myocardial infarction, it resulted in somewhat smaller decrement to health quality of life. For stroke and heart failure, it was more. And for renal failure, it was a little bit less as well. These were all drawn from population values in this publication by Patrick Sullivan and all, a commonly used estimate for health utilities. So after putting all of this in the model, running it through for a patient lifetime, these results are presented in per patient, in lifetime per patient costs. So a little different from the previous analysis we did. And what we see is that for medication therapy management, the lifetime costs of medication therapy management were about $9,000. In the control group, obviously nothing for MTMC costs. Lifetime direct medical costs were $151,000 for MTM and about $153,000 for control, with a difference of about $1,600 lifetime. And then you can see the quality gains here. So again, these are discounted, but we see just under, about 6.7 qualities gained in the MTM group, 6.65 in the control group, with a difference of about 0.08, leading to an incremental cost effectiveness ratio of 93,375,000 per quality gained. So coming in just under that 100,000 per quality gained estimate that we were using as our threshold. In a number of scenario analyses, when we built in amputation and blindness, we saw the ICER improve. So it got lower, and that's because, again, pharmacists, without any additional cost, building in the amputation and blindness into the model led to additional benefits. And then we looked at a scenario where for patients who are well stabilized, maybe they don't have to come monthly, and they could come quarterly instead, because that's something we're always trying to improve the efficiency of our clinic. And so for well-maintained patients who are able to implement all the recommendations of the MTM clinic, we see benefits if we could cut back on the number of visits each year. That would drive the ICER lower for this program, provided it had no impact on the outcomes. Gonna sort of skip over this a little bit. We could see the biggest one-way sensitivity analysis is an analysis that we do evaluating each of the inputs in the model individually and seeing what varying those inputs between reasonable values, how much it affected the cost effectiveness of the intervention. So altering the MTMC cost per minute reimbursement rate seemed to have the biggest impact on the model. The next most important were the hazard ratio for the occurrence of stroke. The hazard ratio is actually for all of the occurrence of all of the events. Seem to have a pretty big impact as well. So those are the ones we would want to get. Those are the inputs we'd want to get better estimates for. We also did another type of scenario analysis where we looked at the willingness to pay threshold and changing that willingness to pay threshold. So this is the threshold that we're using to determine whether or not, or how much we're willing to pay for MTM. And we can see that if we were willing to pay $120,000-ish for MTM services, we reach about a 90% a 90% of 90% certainty that this that MTM is cost effective. So here's the last question. With decision analysis models such as Markov models, do they allow the researcher, decision analysis models allow the researchers to assess which of the following: A, different populations; B, longer time frames; C, different treatment settings; D, all of the above; or E, none of the above? All right, seeing a lot of D, and that is the correct answer. D, all of the above. This was going back to an earlier slide that I had. In our analysis, we did analyze a few different populations and a few different scenarios, and we did analyze a lifetime time horizon. So A and B were done in our analysis. We did not look at different treatment settings, but that's something that had we had different data, different information about what happens in different treatment settings, we could pull that into the model as well and rerun those analyses and see what impact that has on cost effectiveness. So D, all of the above, is the correct answer. So wrapping up, while long-term benefits were considered, medication therapy management services at UI Health were cost-effective for patients with hypertension and diabetes. The benefits from addressing complicated drug therapy in patients with additional comorbidities were not considered in this model. But since there would be no additional cost incurred, any additional benefit of seeing the pharmacist would likely lower the cost effectiveness. So, our MTM clinicians in patients with diabetes don't just address diabetes. They also address mental health issues like depression, and they address, patients might have gout, they may have other things, and all of that is typically included in the visit because patients are viewed holistically. So we're missing those additional benefits that might have been gained. UI Health's MTMC the clinic is funded through 340B and does not charge insurers. One of the issues that we have is we have a proactive approach that makes it challenging to bill for services the way those services are typically designed to pay MTM programs. What we found was that the $2 per minute going rate for MTM services is probably it hasn't been increased since 2005, and it could be increased. And still provide significant value for these patients and for the healthcare system. And these studies provide evidence that increased payment for services could still be cost effective. Limitations, we used UKPDS data, which is predominantly Caucasian younger patients, to predict outcomes for patients in UI Health's MTMC who are predominantly Black and Hispanic. Our program also addresses issues of health literacy and concerns with social determinants of health, which we might be seeing additional benefits there that are not being captured in any of the measures that we're using. Our model does not fully capture the complexity of diabetes and its complications. And the model captures benefits for average change in hemoglobin A1C and systolic blood pressure using the cohort average. It does not address the heterogeneity in the population. So some individuals may have benefited a considerable amount more than other individuals within our program. Those differences are lost in a model like this one. There are other models that can evaluate those types of things, though. And with that, I'm going to open it up to questions.
I can, oh, hold on.